Begin. Good morning, everyone. I'm Howard Chansky. I'm the chair of the University of Washington Department of Orthopedics and Sports Medicine. Welcome to our first grand rounds of the spring. And before we start with grand rounds, there is one kudo that I wanted to mention, and it is in regard to Sean Chang. It was sent by Alyssa Little, who's a nurse in the Seattle Children's Hospital Pediatric Clinic. And Miss Little states that I really hope that Sean will go into peds. He was so good with the kids and parents. He was very proactive in seeing patients, putting orders in himself, communicating with the team, and keeping a busy clinic of new patients staying on time. His attention to detail was greatly appreciated. And she concludes by saying it was nice to see that even on a Friday afternoon, Dr. Chang was enjoying being in clinic and taking advantage of the learning opportunities. It was a pleasure to work with him and was a feeling shared amongst the team. Dr. Chang has received other accolades along those lines. So thank you very much, Sean. And with that, we'll begin our grand rounds. It's my pleasure to introduce Dr. Bruce Sangeorzan, who everybody knows has dedicated his career to understanding the biomechanics and clinical aspects of the foot and ankle, and is a world-renowned expert in the treatment of ankle arthritis. And joining him today is Sagar Chawla, one of our other excellent R4 residents, and they are going to be discussing ankle arthritis evolution in management. So thank you.
I'll go ahead and share my screen. All right, thank you for joining us today. I'll be speaking with Dr. Sangeorzan today on ankle arthritis and evolution in management. This is a real treat for me to get to present with Dr. Sangeorzan. So an overview of what we'll discuss today, we'll start with the epidemiology of ankle arthritis. Then we'll kind of focus on anatomy biomechanics, followed by looking more specifically at the post-traumatic ankle and development of arthritis. And then we'll compare management between arthrodesis and total ankle replacement. So for epidemiology, when we look at all joints and osteoarthritis, we see that it affects about 27 million people in the United States. There's a cost burden of about $185 billion annually associated with this, primarily in healthcare costs. In terms of the post-traumatic arthritis, more specifically, this affects about 12% of all joints. In terms of post-traumatic osteoarthritis of the ankle, it's about 70% of all osteoarthritis of the ankle. It's a predominant type. When we look at sporting-related injuries as being the most common reason, there's about greater than 300,000 ankle-related sports injuries in the United States annually. In the pediatric population, more specifically, this is about 52 ankle injuries per 1,000 athletic exposures in the high school aged athlete. 70 to 85% of patients that are undergoing surgery for end-stage osteoarthritis that's post-traumatic in nature have had a history of some ankle sprain. When we think about treatment, the predominant type today is still arthrodesis, 25,000, compared to ankle arthroplasty, which is about 4,400 annually in the United States. These are 2010 numbers. Surely these have changed by now, and we'll talk a little bit more about that. And in thinking about the patient with post-traumatic osteoarthritis of the ankle, they're about 14 years younger than arthritic patients of other joints, such as hip and knees. Looking at ankle anatomy, the distal tibia flares out, going from a tubular cortical bone to the metaphyseal cancellous bone. The articular surface of the distal tibia is concave, with a posterior lip of the plafond being the anchor point for the posterior part of the inferior tibiofibular syndesmotic ligaments. It also prevents posterior translation of the talus. The medial and lateral malleoli serve as translatory constraints in the coronal plane. Looking at the medial side of the ankle, the medial border is subcutaneous along its entire length, making soft tissue management and soft tissues particularly at risk with any injury. The medial soft tissues of note are the superficial deltoid. It originates from the anterior colliculus and inserts onto the talus, calcaneus, and navicular, as seen here. The primary medial stabilizer is the deep deltoid. It attaches from the posterior colliculus and essentially is an intra-articular ligament. Laterally, there's three components of the collateral ligaments: the anterior talofibular, posterior talofibular, and the fibulocalcaneal. There's also an additional inconstant posterolateral extracapsular ligamentous structure, the fibulotalocalcaneal ligament. It's a local thickening of deep aponeurosis of the leg, and extremes of foot dorsiflexion serves as a resistor. Looking at ankle biomechanics, the empiric axis as divided by Inman is by 83 degrees of varus, and the tibio-talar articular surface is at 93 degrees in valgus. The fit of the talus in the mortise remains congruent throughout the entire range of motion of the ankle. The joint surface is a portion of a frustum of a cone, or what the cone looks like when you take the top off. Its axis of rotation is the rotation of the ankle. The mortise width only changes about 2 millimeters throughout the entire ankle range of motion. Because the ankle axis is oblique, there's an obligatory internal rotation with plantar flexion and external rotation with dorsiflexion. When we look at normal gait, we need at least 10 degrees of dorsiflexion, with athletic activities requiring 20 to 30 degrees. Thinking about post-traumatic ankle arthritis, more specifically in the mechanism behind it, we see that the predominant type of injury that leads to post-traumatic ankle arthritis is an ankle sprain, typically an inversion with the medial aspect of the talus impacting the medial plafond, as seen here. This leads to a talar osteochondral lesion, and then there's a progressive irreversible joint destruction over years after the injury. So what is the primary driving factor behind post-traumatic ankle arthritis? There's two proposed mechanisms, and both likely play a role in any given patient. The first is altered joint mechanics. So we know that there's elevated joint contact stresses from any residual incongruity after any repair, but particularly studies have shown after pilon fractures, and that this is predictive of ankle post-traumatic osteoarthritis. But even with ankle sprains, these will often lead to ligamentous injury and result in recurrent ankle sprains. And 15% of ankle sprains are recurrent. The other factor is acute cartilage injury. And the magnitude of initial injury to the articular cartilage is a major predisposing factor in development of post-traumatic osteoarthritis. We know that the majority of severe ankle sprains do result in osteochondral lesions, and that the majority of patients with these lesions will develop post-traumatic osteoarthritis. However, currently, it's difficult to diagnose these subtle osteochondral lesions in the early phases of post-traumatic osteoarthritis. When looking at x-rays, we typically use the Takakura staging system for classification, with stage 1 being early sclerosis with no joint narrowing, 2 being narrowing at the medial aspect of the ankle, 3A being obliteration at the medial malleolus joint space, 3B being extension to the talar dome, and 4 being complete obliteration of the joint extending to the lateral side. Now we'll focus on treatment options. There's 2 primary treatment options, and of course, being non-operative, being tried prior to either of these. One is ankle arthrodesis, and the other is total ankle arthroplasty. And we'll focus the bulk of our discussion from here on these 2 management options. So for ankle arthrodesis, the indication is end-stage osteoarthritis, with pain, stiffness that's not alleviated by non-operative treatment. The ideal position of the hind foot for fusion is neutral flexion, 5 degrees of valgus, 5 to 10 degrees of external rotation, and about 5 millimeters of posterior talar translation. Ankle arthrodesis is known to relieve pain. It improves function. It leads to a decrease in sagittal plane range of motion of the hind foot. There is some subtalar complex motion that increases about 11 degrees in the first year after arthrodesis, and patients maintain midfoot range of motion. The non-union rate is about 10% and being about 3 times higher in smokers. For total ankle arthroplasties, there's been 3 generations of implants that have come out, each with different challenges. The first generation came out in 1970. They had a higher rate of failure and had a number of limitations. Failures were often related to severe osteolysis, component loosening, impingement, infection, soft tissue breakdown. There was also a number of failures noted early on due to technique, being an early implant and a new technique in terms of inadequate fixation, poor soft tissue management, malalignment, and lack of soft tissue balancing. In terms of the types of designs, there were 2 types of failures of design. One were the highly constrained designs. These had excessive transference of shear, compression, and rotatory forces associated with weight bearing to the small area of the bone prosthesis interface. These implants also required considerable amount of bone resection, which made subsidence more common. There were also the failures due to highly unconstrained designs. These had less component loosening, but were unstable and often impinged on the soft tissues in the malleoli. The second generation of components had 2 types of implants as well. There were the mobile bearing type. These had a moving polyethylene bearing, which separated a convex talar component from a flat tibial component. There was an increase in design complexity. It added the risk that the bearing could become dislocated. And there was also a concern that this second articulation may generate additional wear particles. There were also the fixed bearing designs. These had 1 single articulation between the tibia and the talar component. There was a lower risk of dislocation, but since they had just a single articulation, they tended to produce more wear products. There was a trade-off between reducing constraint versus stability. The third generation of implants has tried to strike a balance, as well as being better to soft tissues in terms of these are 3 component designs. They have an independent polyethylene component that's a mobile bearing meniscus. There's a greater importance given overall to the ligaments to maintain overall stability, and there's a need for anatomic balancing following the component insertion. There's also far less bony resection required. Next, we'll look at a number of studies that compare ankle arthrodesis and total ankle arthroplasty outcomes. First, I'll start with a survey about what surgeons typically do. So this came out in 2020. This was a survey of orthopedic surgeons, 103. Majority were male. Most were between the ages of 41 and 50. There was equal balance between the community and academic surgeon, and about 20% had done a foot and ankle fellowship. So looking at the average number of arthrodeses that were performed, most did about 1 to 10 per year. Very few, about 20%, did even 1 total ankle annually. The majority did at least 1 ankle fusion annually. When thinking about why this was done, common reasons for not doing a total ankle were lacking training, did not believe it was effective, or lacking institutional resources. So I wanted to compare or find a study that compared total ankles to fusions in terms of return to activities. So this was a study done in 2012. There were 20 total ankles, 21 fusions. They looked at the preoperative sports participation of their patients, which were about about, they were similar, 86 to 76 in terms of fusion to replacement. Post-operative sports participation between the groups was similar, 76%. And both groups had very similar UCLA and AOFAS scores as well as satisfaction scores. So we can see the UCLA scores here, AOFAS scores here, and satisfaction scores here. One thing that was noted was that although patients remained active, the types of sports they tended to gravitate towards were different. So for example, this white bar here represents preoperative total ankle replacement, and this gray bar here is postoperative total ankle replacement. You'll see that skiing has fallen out of favor. Whereas if we go to hiking, just above it, we see that there was actually an increase. They did this for a number of different sports and activities as well, and there's similar trends in terms of swimming, hiking, biking being preferred to things like tennis and dancing. Next, the question I wanted to explore was, how is gait and ankle joint mechanics affected by arthrodesis and arthroplasty? So this study had three groups. They had arthroplasty with a hind foot fusion, and ankle fusion. So in their gait analysis, they found that all total ankles with or without a hind foot fusion and arthrodesis had no difference in cadence, stride length, or walking velocity. In their kinematic analysis, they found that a fusion had the greatest reduction in sagittal range of motion of the ankle, which would be expected, and this was compensated by greater knee range of motion in the gait cycle. AOFAS scores overall showed that an ankle without a hind foot fusion did better than a fusion of the ankle, and the worst was a total ankle with a hind foot fusion. And this is represented here by the AOFAS global scores. Interestingly, they also noted that patients that had an overall higher preoperative range of motion lost motion. So if you had range of motion of about 50, you had post-operative range of motion that was lost, maybe -10 to -15. Whereas if you had a lower preoperative range of motion, about 10, you ended up gaining about 10 to 20 degrees. Next, we can compare both surgeries, fusion and arthroplasty, to normal controls. This was a study done in 2013. They had two different types of implants for their total ankles. In their study, they noted that total ankles had a greater postoperative sagittal plane range of motion, and this was primarily in dorsiflexion. And we can see that here in terms of these being the controls, being the highest bar, followed by arthroplasty, and then finally by arthrodesis. And we can see that in terms of dorsiflexion, arthroplasty and normal controls have about almost equivalent. They also noted that plantar flexion was not equivalent in either group, and we can see that here, with arthroplasty actually being the lowest group compared to controls and fusion. They also noted that the gait pattern was not normalized in either group. And this is their gait pattern chart in terms of controls, having much higher peak angle power compared to arthroplasty or fusion. Arthroplasty being the solid line, black line, and the dotted black line being fusion. This may be a limitation of arthroplasty, is that they chose, both being a second generation and neither design being able to reproduce the posterior malleolus of the ankle, which would limit plantar flexion peak power. This was another study with similar design and implants trying to answer a very similar question. Again, they used the STAR components. They had 14 fusions, 14 ankle replacements, and they also had healthy controls. They had 1-year follow-up. They used a 3D gait analysis with motion capture system. They found that ankle arthroplasty had the greatest improvement in walking velocity and step length. So looking at their post-operative fusions, and total ankles, we see that the greatest increase was for total ankle arthroplasty. And this is similar for step length. Total ankles also had better sagittal plane range of motion. And total ankles had greater improvement in coronal plane eversion. Additionally, total ankles were more symmetric in comparing to normal controls in their gait cycle compared to arthrodesis, but it was not significant and not actually normal. And that's seen here in terms of the star component post-operatively compared to the normal control. This is another study, again, with a 1-year follow-up looking at both fusions and arthroplasty using a motion capture system. And they find that within each group, the gait velocity, stride length were improved. Between groups, there was no statistical difference. And this study out of University of Washington also found that total ankles had minimal change in step count post-operatively, but notably, there was actually a decrease in the arthrodesis group with an 11% decrease. And that's seen here with the step count data. Total step counts, relative change was negative 11% for the arthrodesis group. It was a 0.5% increase in the arthroplasty group. They were also able to measure the ankle moment. They found that fusions had an increased moment in plantar flexion postoperatively, whereas total ankles had a decrease, and that's seen here. This may be because the talus is fixed to the tibia with the fusion, which is able to provide a rigid system. Next, I wanted to see whether these functional outcome gains were maintained at longer-term follow-up for patients. So this was a study that was published just this year. This is a study out of Baylor. It's unique because they have a minimum 5-year follow-up with a mean follow-up of 7.6 years of 33 total ankles. They used motion capture system. For their gait outcomes, they see an increase in gait cadence, step length, and walking speed. So an improvement across the board. In terms of range of motion as well, they see that total sagittal plane range of motion, plantar flexion at initial contact, as well as the maximum plantar flexion, all improved post-operatively for their patients. A study that we've been working on here at the University of Washington with Dr. Sangeorzan has been trying to define success with either fusion or total ankles and looking at predictors of success. So the question we wanted to answer was what demographic and radiographic preoperative factors are associated with success after ankle arthrodesis and total ankle replacement. To define success, we used the foot and ankle ability measure, the activities of daily living subscore, and we wanted to see both an improvement that was greater than the MCID, the minimal clinically important difference, which is 9 points in that score, as well as the patient having no revisions or complication. So we had 448 patients, mostly total ankles. We had a minimum of 4-year follow-up. We found that the majority had a successful outcome. Of those that had a successful outcome, factors associated with this were female sex, treatment with total ankles, and no previous surgery. Factors not associated with success, and I want to highlight here, is mental health, although this has been shown or pointed out in other studies. And more interestingly, is preoperative radiographic measurements. And we use coronal tilt as well as sagittal subluxation. It's very interesting that these are not associated with success. And last, I'll conclude with this meta-analysis looking at failures and revisions of both groups, fusions and arthroplasty. So meta-analysis comparing 10 studies. They found overall complication rate is higher in fusions at almost 27%. Revision rate is higher in total ankles at about 8%. And total ankles had a more symmetric gait and less impairment on uneven surfaces, as would be expected, given the maintained motion. For fusions, complications most commonly were wound healing, followed by non-union. And for total ankles, it was deep infection. Reasons for revision for total ankles most commonly were aseptic loosening, more commonly with older implants, but also still persistent with newer implants, as well as for fusion being non-union. So in summary, both fusions and total ankles are options for post-traumatic osteoarthritis of the ankle. Fusions have a higher complication rate. Total ankles have a higher revision rate. Patients can maintain an active lifestyle with either. In terms of ankle kinematics, studies show mixed results, but overall, total ankles are biomechanically closer to the healthy control. Thank you.
I should be unmuted here. So that was a great summary by Dr. Chawla. And what we're going to do is look at about 17 or 18 years of research that we've done here at the University of Washington. So I don't have any commercial conflicts of interest. This all started back in the 1990s. We were sitting in an X-ray conference and saw a couple of patients with ankle arthritis who had previously had triple arthrodesis. And we didn't have a very good solution, and we were just chatting about how nice it would be if we had an ankle replacement. And Frank Alvine, who was a colleague of Dr. Hansen's from residency, had designed one, and I was the program chair at the AOFAS that year and saw his abstract. And Dr. Hansen invited him out to chat with us, and we started this research plan. So the plan at the beginning, around 2002, when we started looking at Grant with Dr. Ledoux and Dr. Orendorf over at the VA lab, here's a diagram from NIAMS on arthritis. You notice that the neck, the back, the hips, the knees, the wrists can have arthritis, but there can't be any arthritis in the foot. So we knew we had a challenge going forward, convincing people that this was meritorious of some kind of funding. So ankle arthritis is different than hips. Primary osteoarthritis is very uncommon, and Sagar went over the mechanics of the ankle and how unique they are, and it's much less likely to be symptomatic. In an early study from the University of Iowa, nearly 3/4 of ankle arthritis patients start with trauma, and it's probably much lower than the 7% idiopathic reported on that study. And part of the reason is we don't understand the morphology of ankle fractures very well, or I'm sorry, of ankle arthritis very well. This was a study that Dr. Ledoux and I did with a medical student research and training program student, Kristen Schaefer, which we took the CT scan of 108 limbs that were normal controls, ankle arthritis without trauma, a cavus foot and a flat foot, and we compared their shapes, including the radius, the coverage angle, and skew. This is a diagram of a CT in the sagittal plane, and this is the model we made from it. And the green line represents the curve of the talus, and the red line represents the curve of the tibia, looking at the coverage angle. So the things we looked at are radius, skew, the difference between the paths that these two take, and the coverage angle, very similar to the center edge angle that you see in the pediatric hip. And not surprisingly, we found that ankles with osteoarthritis had larger tibial and talar radii, in other words, less curved, so that it's more likely to shuck back and forth, had a smaller coverage angle to concentrate the forces, and there was more skew between the talus and the tibia, Now, granted, these patients already had arthritis, so we don't know if that was cause or effect, but there were clearly differences that just addressed the mechanics of the ankle in the patients that were thought to be quote unquote idiopathic ankles. So we also looked at the functional limitations. There wasn't much known at the time. I got a group together and we looked at patients with ankle arthritis and used the MFA, the Musculoskeletal Functional Assessment tool, to compare those patients, again, to other areas of arthritis like the hip and the knee. And the results of that study showed, to my surprise, that the mobility of an ankle arthritis was more severe than the mobility limitations from hip arthritis. And not surprisingly, since this population is about 15 years younger, there was a greater impact on work life. This study was repeated using the SF-36 a couple of years later. So ankle arthritis has greater impact. The patients are younger. It's mostly mechanical. The bones are smaller, and the axes of the two bones are orthogonal. They're not linear like a hip and like a femur and a tibia. So we then expanded that study to include kinematics and kinetics over in the VA lab under Dr. Ledoux's direction. And we applied that same question, how limited are these patients with end-stage ankle arthritis? But in this time, we included gait kinematics and kinetics and step counts using a step activity monitor. This was before iPhones and before Fitbits, and in order to do that, you had to attach a little tool to the patient. So we found out, as Sagar mentioned, that there were fewer total steps, but much more importantly, there were fewer high-intensity steps. So in other words, if you're walking through a grocery store, it's going to take the same number of steps to get through there. But if you have ankle arthritis, you take a few steps and stop and take a few steps and stop, whereas patients who don't have ankle arthritis will just walk continuously. Gait analysis, Sagar covered nicely already. So what do we do about it? We brace them, we clean them out, we distract them, we realign them. We can do mosaic plasty, but ultimately it gets down to arthroplasty and arthrodesis when you get to end stage. And the world of bracing has dramatically improved as well. Even a simple over-the-counter brace can be effective. This articulated Ritchie brace or articulated AFO is pretty much gone the way of the wagon wheel. It's not used very much. It's very bulky and expensive, and it's largely been replaced by lightweight carbon fiber devices like this toe-off or an Arizona brace, or in the more complex cases, a dynamic patellar tendon-bearing brace that goes under a number of names, originally developed by Ryan Blank, who's here in Gig Harbor. So you start with the non-ablative procedures. Kylectomy is aggressive removal of marginal osteophytes that get in the way of the ankle. Try to restore native anatomy, and sometimes with a soft tissue release. You can combine that with a small pin distraction with some weight bearing allowed, and you do see some degree of regenerative stimulus under those circumstances. So here's a classic kylectomy. We cleaned out the talar neck, not the tibia, because we know that if you lose this containment, you're worsening the mechanical environment. So the kylectomy is done on the talar neck side. And if you look to the right screen, you see that patient 3 years later with a relatively maintained joint space and a nice clean talar neck. When it's closer to end stage, you can combine that with a distraction kylectomy. This is a small pin. There are some newer devices that make this a little bit easier to do now. This case is from around 2000. And here's the before, and here's the after at 2 years. It's not great, but there's improvement, and you can buy time with this. Say your patient's 50 and you want to wait until 60 to do a fusion or replacement. This can be effective. This is a patient of mine with 15 years follow-up. She was 39 when she originally presented with this end-stage ankle arthritis, no joint space, poor containment, and after a distraction and a kylectomy, at 2 years, she was doing pretty well. At 12 years, she's still doing pretty well. She's now about 16 years out and has some arthritis and probably on tap for a fusion or a replacement. But the key to a kylectomy's effectiveness is recognizing that most of the disease is on the talar side, not the tibial side. And if you look at these sagittal plane CTs, you can see a large mass of bone forming that blocks dorsiflexion. And when the foot tries to dorsiflex, it hinges open and wears out the front of the ankle. And on the CT in the upper right-hand corner, you see where the native neck should be and where the new bone has grown up to fill that neck. Your goal of kylectomy is to restore that curve So here's a more recent patient, clearly hinging in the front. We rounded that off, and here he is post-op, there he is pre-op, and 3 years later, you can see that there's still some motion, although there is some narrowing. And if the deformity is coronal plane, you can correct that instead of ablating the ankle. Here's a patient who had a varus deformity that was fixed with an inverted dome osteotomy and allowed him to get planar to the floor so there wasn't wear along the medial side. But eventually, it all comes down to fusion or replacement. And in the world of comparative effectiveness, if you have two effective tools, then you need to see on a more granular scale which one should be used and how much correction you can get and how much the patients need it. And we know that arthrodesis works very well. It addresses instability and pain, but it is not indicated in the presence of subtalar arthrodesis. And it has to be done well, preserving this angle of inclination of the talus versus the tibia to prevent rapid reduction of the subtalar joint space. This is a patient, a long-term patient of René Marty, who shows that there's hypertrophy in the Chopard's joints or in the motion of the Chopard's joints, so that ankle arthrodesis over time continues to work pretty well. Here's a patient who is 6 months after an ankle arthrodesis, and if you're not paying attention to where the motion is coming from, you can see they can do quite well. Over time, that motion diminishes to some extent in some patient. Here's a patient 7 years out from an ankle arthrodesis who I was trying to talk into an arthroplasty for his other side, and he declined and said, I'm not giving up this great operation that you did on the left. So it is a good operation. Ankle replacement came along because it's not a perfect operation. And we've been doing them here since Frank Alvine visited in 1996 and brought the agility ankle and showed his fellow classmate, Dr. Hansen, how to do them. And we now know that these last a long time. When we started doing these patients, we were having failures at 4 or 5 years. But these newer devices, now we have follow-up out to 17 years in some of these patients from the first study, and they're still doing well. So which one's better? This patient has a fusion on one side and an arthroplasty on the other. And you can see that there's not much difference in gait under normal circumstances on a flat surface when you have shoes on. Those differences are shown if you're not in shoes and if you're on a ramp, but for the most part, they're both quite effective operations. So when we decided to compare them, we tried to get some funding to make that happen, and Dr. Ledoux and Orendorf and I tried to put together a study, and while we were doing that, a few controlled trials came out. A prospective study of the STAR prosthesis was done with 158 ankle replacements and 66 fusions. The fusions were done by one group of surgeons and the arthroplasties were done by a different group. And they were studying these as a non-inferior as opposed to a direct comparison because it was required for FDA approval of the device. And they found, like others, that TAs were not inferior for pain and better for function, but had a much higher revision rate. But over the course of that study, the revision rate was reduced by about 40%. The biggest and best known study comparing them was by Daniel's group in the COFAS, Canadian Orthopaedic Foot and Ankle Society. And they looked at 300 plus patients and again found the adverse event rate was 3 times higher in ankle replacements, but they did not find any primary difference in their primary outcome measure, the AOS or the SF36 in the two groups. Now there's a problem with their measurement tool, which we'll get into in a second. But ideally, what you really want to have is a comparative trial that was randomized. That is the gold standard for evidence in medicine, but it is very difficult to randomize in surgical trials, particularly when you can't be blinded. The incisions are different, the motion is different. You can't really blind a study like that. And surgeons have different skill levels, so you have to make sure the procedure is being done by the same surgeons in both groups. So we set out first to do a cohort study and then to do a prospective cohort with a randomized clinical trial combined. In order to do that, we needed to know the disorder's impact. We needed an instrument that measured that impact and that met all the validation criteria for psychometrically sound outcome. And we wanted to stratify the subjects as cleanly as possible and objectify the data analysis, because we surgeons are not objective. And if we collect the data, it's not going to be accurate. So we had to find a responsive patient-reported outcome measure. The AOS, which was used in the Canadian study, is not a responsive instrument, has a very low ceiling. And if you have 2 effective treatments, it's not going to be able to detect a difference. And we wanted to narrow the differences by having the surgeons who did one treatment do the other, and then compare the individual patient's starting point to their finishing point rather than using population studies. So we asked the patients what was most important to them. We had about 200 patients in that study, asking them what are the things that are most important, and not surprisingly, using the MACTAR format from the McMaster Arthritis scale, that the most important things were walking, running, standing, and exercise, with the highest priority being to running. So we then looked at outcome instruments that captured those issues and placed a higher priority on them, and identified the MFA, the Musculoskeletal Functional Assessment, which was developed at Harborview and Johns Hopkins, the FAM, which was used by the physical therapy literature. They were both good measures that were sensitive, valid, and had good psychometric qualities. So we started out with a cohort study funded by the VA because the NIH did not fund our preclinical trial. And we planned to study 100 patients. This was just at the time Dr. Hansen and myself, but we ended up expanding that trial over years to include some of our past fellows. And that study had 273 patients in it, roughly equally distributed between fusions and replacements. And then we turned that into a multi-center clinical trial funded by NIAMS that had 522 patients. So I'm including data from both of those studies with 203 ankle fusions and 667 ankle replacements. So we basically enrolled patients who had no inflammatory disease, because we thought that would impact their outcome score, and no other lower extremity problem. They had to be eligible for both procedures, and the surgeons that we included had to meet strict criteria. They had to have 5 years of experience performing each procedure. They had to have done a minimum of 100 weight-bearing joint replacements, and this included hip and knee replacements. They had to have done at least 10 directly supervised ankle replacements, and they had to have done enough fellowship training to know how to straighten out a crooked foot. So those were the criteria. We set out to test them before surgery and after surgery at 6, 12, 24, and 36 months. And they wore a stepwatch activity monitor. This was before 2006, no iPhone, no Fitbit. And we used strobe reporting to get to the data. The MFA is a highly validated functional outcome tool that's patient self-reported. Higher scores indicate relative reduced function, and it's validated in a population of younger patients with post-traumatic arthritis, which is close to our study population. The SF36 is a well-known self-reported outcome scale with 36 items and 8 scales that cover mental health and physical health. They are not specific to the musculoskeletal system. And we added a pain score and a function score. So in our first trial, the participants who received an arthroplasty were older by 3 years, had significantly lower mean BMI by 2, and those undergoing arthroplasty had a higher 3-year completion rate. And in that group of 273 patients, 103 of them had an arthrodesis, 170 had an arthroplasty. 100 of those were the new generation of ankle, and 58 were the old generation. 74% of the patients were from the University of Washington system, specifically Dr. Hansen and myself, and then 26% were from other centers that were recruiting for the next trial. At baseline, there was no difference in the two groups in their MFA scores, their SF36 scores, the step activity measures. The only differences were the weight and the age. So that published paper showed a comparison of those two groups, and there were actually 3 groups: arthrodesis, arthroplasty with the old implant, arthroplasty with the newer implant. And this is a very busy scale, but it basically showed that there was a difference between arthroplasty and fusion favoring arthroplasty in pain, in the MFA score, in the physical functioning score of the MFA. And this was carried out beyond just arthroplasty and arthrodesis to show that the newer devices had a better overall decline and a faster decline in the MFA score, which is the same as saying a better recovery. The physical function scores, again, had a more rapid improvement and a higher improvement in the newer generation, although the DePuy scores were also higher than the fusion scores. Pain scores followed a similar trajectory. It is deeper and it's faster in the newer device, but both arthroplasty devices were better than the fusion in the direct comparison. So that was primarily a Salto device, but during the next trial, we added in-bone devices, Zimmer devices, Infinity devices, and Vantage. Any study that, any device that was regulated and done by one of the surgeons could be included in the study to give this a pragmatic outcome. And finally, we added the step counts. Again, this was before the iPhone was out, and we wanted to have an unbiased view of how active the patients were being, because the patient-reported outcomes are subject to some degree of bias and mental health issues. So the step count activity monitor looks like a prison release device that gets strapped on the ankle, and we use this at the same intervals that we use the patient-reported outcome measures. Patients walked with it for 14 days. We got total steps, high activity steps, medium activity steps, intensity periods, things that we can go over in the question, and sustained activity. These are all measures of activity, and we compared those again in comparing the arthrodesis group and the arthroplasty group. And we found that there was, again, no difference in their activity before treatment, and that the arthrodesis group was younger and heavier. But in all of the treated patients, there was an increase of about 11% in the total number of steps they took. And there was about a 50% increase in total steps from treatment altogether. There was no change in the low activity steps, and the high intensity activities improved a lot more than the low end. And BMI and sex did not have any effect on outcome. Unlike the patient-reported outcomes, this is a way to look at their activity independent of the patient's perspective, BMI, or other health factors. And I'll shorten this by saying that the arthroplasty group walked much faster than the arthrodesis group. In fact, they had increased already by 6 months, whereas it took the arthrodesis group almost 2 years to get back to baseline, and it took the arthrodesis group 3 years to get to the level of step activity that the arthrodesis group had. So now we know that patients undergoing arthrodesis had slower improvement, fewer steps initially, eventually caught up, but their pain scale and their functional outcome measures did not catch up during that 3 different periods, during those 3 different time counts. And we know that step activity has a different trajectory of improvement than PROMs. The PROMs got the vast majority of their improvement in the first 6 months, but it took almost 2 years for this step activity to come back to normal. So there is a difference between patient-reported outcomes and measured outcomes. So if you wrap all that up in the short term, which is what we'd consider 2 to 3 years, both ankle arthrodesis and ankle arthroplasty are very effective treatments for ankle arthritis, but the ankle arthroplasty patients did better on almost all measures. So can that hold up to a bigger study in more sites, if you include more sites and more time? So we had expanded the study to include multiple other sites. We followed more or less the same protocol, but added additional measures for outcome. And we compared that group at 2 years from 6 centers with a little over 500 patients. And looking at, this is a quick review of how the patients broke out, not critically important. This is a list of the ankle implants that were used during the device. And again, we found that both ankle replacement and ankle fusion were highly effective at removing pain and improving patient-reported outcome. But in each one of these groups, ankle replacement had a better score, that is lower pain, higher functional self-reported outcome. These are graphic representations of the same thing, with the black bar being the average. And you can see that the FAM score improved faster and went higher than it did in the arthroplasty. These are the two groups grafted on the same graph, so you can see the difference. And the FAM followed a similar trajectory, and the SF36 followed a similar trajectory, and the pain scores followed a similar trajectory. So again, with an expanded population, So the outcomes were good in both groups, better in the arthroplasty group. Mental health, as Sagar mentioned, had no impact on the study in any way. The arthroplasty and arthrodesis patients had the same non-effect from lower mental health scores, and the mental health scores did not change. So this is different than hip and knee arthroplasty, I know, and it is worthy of looking into. So these were short-term follow-up, greater improvement, but younger patients had more improvement, surprisingly, and lighter patients had more improvement, not surprisingly. Activity measured by wearable technology was different than those reported by self-reported outcome. So that's all 2 and 3 year data. And we know that the literature says there are 3 times as many adverse events in the arthroplasty group than the arthrodesis group. So we looked at all of our adverse event reports sent to the NIH. And anyone who's done NIH reporting knows that that's a very detailed process that doesn't leave anything out. So we looked at those rates. There were 628 adverse events reported. The vast majority of those had nothing to do with a study, but were reported anyway because of reporting requirements. We divided them into 4 groups: unrelated to the ankle, related to the ankle but not requiring a second operation, having a second operation but not having activity restriction, and having a revision operation that required non-weight bearing. So it's that 4th group, that's the big one. Same population with 500 patients, and adverse events occurred in 63% of the arthroplasty group and 65% of the arthrodesis group. Remember that adverse event can be pain, it can be a cough, it can be pneumonia, it can be anything that happens to the patient during that time. 8% of these studies were actually, of the adverse events were actually related to the ankle. It was 8% in the ankle replacement group and 17% in the arthrodesis group. And when we adjusted for confounding variables, we ended up finding out that there was no actual difference in the rate of adverse events, but the adverse events had a bigger impact on the arthrodesis group in impacting their outcome measures. Surprisingly, again, mental health did not have any effect, and medical comorbidities as measured by functional comorbidity index did not predict adverse events and did not predict what the self-reported outcome will be, as Sagar mentioned earlier on. So at short follow-up, all the measures show ankle arthrodesis is very effective, ankle arthroplasty is very effective, but more effective, statistically more effective than ankle arthroplasty was. Any day now, the minimum 4-year results are going to come out in the same population, and it's the same study, just followed longer. We're down to 82% follow-up at this point. Both ankle replacement and ankle arthroplasty achieved significant improvement in pain, functional measures, and everything except present pain. And the arthroplasty group had a higher improvement than the arthrodesis group. So we can conclude, when performed by fully trained orthopedic surgeons, both arthrodesis and arthroplasty result in clinically and statistically sound improvements. At 2, 3, and 4 years, arthroplasty patients reported better outcomes and lower pain. Patients with newer implants have more improvement compared to older generations. And at 1 and 2 years, arthroplasty patients took more steps and had higher intensity step activity, but by 3 years, those were no longer different. So a little caveat, this was not a randomized trial. We attempted to randomize the patients, but we could not get enough people to be willing to randomize to continue it as a randomized trial. So it's just a cohort study that's been adjusted. And in the real world, you can't control the surgeon doing the procedure, so the outcome events are likely going to be a little bit different. I just want to acknowledge my study team and Dr. Hansen, who inspired this group of studies, and the NIH and the VA and our study coordinators listed here. Thanks for your attention.
Thank you, Dr. Sangeorzan and Dr. Chawla, for that excellent presentation. Dr. Chansky is having some connection issues at the VA, so he asked me to corral some questions. So that was a really great synthesis of a pretty daunting topic, so thank you for bringing that together. So we can now open the floor to some questions if anyone has any.
Yeah, this is Vince Muska. Can you hear me?
Yes.
Good. Yeah, I thought both of those talks were fantastic, and this is out of my wheelhouse. But I was impressed when Sagar was talking about the motion in the sagittal plane after ankle arthrodesis, which obviously implies that the motion is in the subtalar joint and or Chopard's joints. So, Sagar or Bruce, are you studying what's happening with the subtalar joint? Because with an ankle arthrodesis, things might be okay short term, but the subtalar joint is going to try so hard to be both joints that there must be some negative long-term effect on the subtalar joint with the ankle arthrodesis compared with the total ankle arthroplasty.
So the answer is yes, it is being studied, not perfectly so, but it is being studied. Amanda Stone, who's one of Bill Ledoux's grad students, just put a paper together looking at gait kinematics. From a clinical standpoint, I'm not sure we can draw conclusions. Bill Ledoux also has something called a biplanar lab at the VA, where we're going to be looking at that exact question. What are the motion segments? In the biplanar lab, you can look at individual bone motion rather than a traditional gait model where you're looking at multi-segment models with attached markers. So hopefully sometime in the next couple of years, we'll have a little bit better data to answer that question.
Great, thanks. Sagar, do you have anything to add?
No, not at all. It's great.
Dr. Sangeorzan, this is Will Lack. I was going to ask you about just something that I was trained in residency, and I don't know how others feel about it. And do you, from your own experience and from the research that you've done, do you feel that there's a difference in the complication rate with open or arthroscopic ankle fusion? And was that looked at all in the study within the subgroup of fusion?
We actually just did a podcast on JBJS on that exact question this week. There is a study done by the COFAS group, Canadian Orthopaedic Foot and Ankle Society group, where they combined data on ankle arthroplasty using their best performing implant, ankle arthrodesis done open, and ankle arthrodesis done arthroscopically, and found that the ankle arthroplasty and the arthroscopic ankles did better than the open ankles. However, it was retrospective, and the reason for doing open was because it was more complicated, and the less experienced surgeons were doing the open group. So to your direct question, I don't think we have data that shows one is better than the other. There are certainly strong advocates for one procedure over the other, but I don't think we're there with data that can make that conclusion for us.
Yeah, I would just, my follow-up on that is just that I thought it might be hard to get such data. My experience of talking to other people who do many more ankle fusions than me is that people have their own way of doing it. And it's like many things we do might be mostly related to the specific technique and then the problems with those individual patients, but thanks.
Yeah, I think that's a good point, that how it's done is probably less effective or less important than the results of the fusion. If you do a beautiful arthroscopic fusion but leave the talus in 15 degrees of plantar flexion, the outcome's not going to be very good in the long time.
I had a question. So total ankle replacements, many years behind total hips and total knees, and it's still constantly evolving. Dr. Sangeorzan, you've been doing this for 20 plus years now. Have your indications for ankle arthroplasty changed over those 20 years as implants have changed and we learn more about this?
Yes, mine have. I'm not sure if other people have, but at the time in 2003, when we put the first proposal together, Dr. Hansen was a strong believer in arthroplasty, and I was still doing 80+% fusions. I was only doing arthroplasty if patients had had a prior triple or they had disease in those joints. Over time, our whole organization has moved much more strongly to arthroplasty because of patient satisfaction. And while I do think we're a world behind knee arthroplasty and hip arthroplasty, satisfaction rate for ankle arthroplasty is in the low 90s, which is quite a bit higher than the satisfaction rate for total knees. And that may, of course, have something to do with patient selection, and the fact that arthroplasties tend to be done in centers. But I don't know. I think we're definitely getting there. One of the last year's fellows pulled all the patients who were more than a decade out from their arthroplasty, and 92% of them are still happy with what they have.
Thank you. Are there any other questions from the audience?
Hey, Greg Schmalley here. A question for Dr. Sangeorzan. I'm a big fan of Lou Zirkel's work with sign fracture care, and all over the world, people are using his nail to do a retrograde fusion across the calcaneus tibia, talus, and tibia. And I'm wondering if you've taken care of any of those patients after that sort of fusion, and what your concerns are with that sort of treatment. Thanks.
Yes, I have taken down pan-talar fusions and converted them to an ankle arthroplasty. And I don't know if Dr. Bragi's on and wants to pipe in, but we've probably done about 120 conversions of prior fusions. A substantial number of those had a prior subtalar fusion. I can tell you that the outcome is not as good as a primary ankle arthroplasty is. And we are in the process of looking those patients up now to try to get a metric to measure that outcome by. It's more technically challenging for sure, but it remains a possibility because patients in general don't like pan-talar fusions. While ankle fusions are very effective and useful, pan-talar fusions are far less so.
Thanks.
Okay, well, thank you again, Dr. Chawla and Dr. Sangeorzan, for an excellent talk. Everyone have a good morning and have a good day.
Nice job, Sagar.
Thank you, Dr. Sangeorzan.